We have a checkered past and a long list of tasks that we've performed poorly on. Think about race relations. Think about use of force. Think about the case law that's been handed down to us by the United States Supreme Court. On the flip side, we had an uncanny ability to get it right. Think about the Boston bombing response. Think about the FBI rescue in 2013 of the kidnapped boy from the bunker in Alabama. Think about the heroics that we see from everyday patrol officers on duty in their jurisdictions and the incidents that we capture on video. We can't move forward without understanding history, or we might be doomed to repeat it. Today's contemporary police leaders need to be willing to adopt best practices and new ideas. We have to partner with our communities to break barriers. As we jump into the discussion tonight, I want you to think about someone you know who struggles with mental illness. While we're talking tonight, I want you to keep their face in the back of your mind as we talk about this new community issue. Mason City, Iowa, sits on Interstate 35 in north central Iowa, halfway between Minneapolis, Minnesota, and Des Moines, Iowa. We're a community of 28,000 people. We're blue collar and we're proud of it. We are the hub for 9 counties in North Iowa, and we are the central large city for that region. We have a large hospital, we have a large retail presence, and we're also home to most of the mental health providers for that North Iowa area. Most law enforcement agencies across the United States use some sort of call for service measure as we measure statistics. Sometimes it's the demand for police services. Sometimes it's how busy we are and what we're doing. We track different things that we do this way. What I have for you for the data set on the screen is calls for service at the Mason City Police Department for welfare checks from 2012 to 2018. I want you to pay particular attention to the year 2014, 2015, 16, and 17. You'll begin to see the uptick in welfare checks that we experienced as a department during that time. Mental health response from a public safety standpoint is not a fast call for service. Sometimes these are calls that can take hours for officers, and sometimes it's multiple officers, depending on what we're called to. I want to try to put in your mind a cost on this for us from a public safety standpoint. If I have 2 patrol officers that respond in separate vehicles to a call of a person in a mental health crisis, that cost to me is about $85 an hour. If the officers get there and they discover that we need an ambulance because there's some sort of additional medical or mental health issue that we need to use the paramedics for, those 2 firefighter paramedics and the ambulance are another $105 an hour. If we end up going to the emergency room, which we do in many cases, that's $1,800 for at least the diagnostic triage of the problem with the patient that day. That's $2,000 that we've spent in hour 1 treating a mental health situation. You might ask, who cares? How does that affect me? We're all taxpayers of some kind in this room. And in our communities, public safety response is funded from general fund dollars. And so those costs are directly passed on to our taxpayers. We also don't do a lot of great follow-up in the traditional public safety response to mental health when someone's done at the hospital. We take them there, they're triaged, they're treated, and they're released. And then they go back into the same environment they were when we found them. I don't think it's a surprise to anyone that calls for service continue to go up. We don't communicate well in that system traditionally. The hospital isn't talking to mental health providers about who was there and what happened with them. So there's no safety net, there's no support system to plug them back into. A lot of times law enforcement, we walk into all kinds of unknown situations with people who are in mental health crisis. Our actions sometimes are driven by their actions. And sometimes that ends in personal injury or death for the patient or for an officer. And we also tend to criminalize mental health from the standpoint that mental health patients typically don't have a lot of resources. And sometimes the easy solution for the police is arrest for things like public intoxication, criminal trespass, or minor theft. So is this the best approach? When I got to Mason City, I'd learned about this problem and we began to study it a little bit. I drew on my experience of nearly 20 years with the Ames Police Department right here. We had experienced a similar phenomenon in years prior to this with an increase in calls for service. During that time, our approach had been to assign a detective part-time to follow up the day after a patient went in for mental health treatment at the hospital. We weren't always successful, but we were at least trying to start the dialogue with people in the community who could make a difference. Eventually, that position morphed into someone regular part-time and nearly full-time, following up in a mental health advocate role and trying to impact the overall outcomes for mental health patients. In Mason City, when I got there, I didn't have the ability to do that. There weren't resources available to me. And we were already having a community discussion about what this solution might look like. That led to a discussion with County Social Services. County Social Services is a 22-county consortium in North Iowa, in North Central and Northeastern Iowa, that provides funding to mental health patients and those with disabilities who can't provide for their own resources on their own. The discussion that we had very quickly turned to outcomes and how we might be able to work cooperatively to impact that. Before long, we had a 2080 agreement, which is an intergovernmental cooperation agreement to employ a justice coordinator at the Mason City Police Department, but funded through County Social Services. The justice coordinator was a new position, and the idea here was that this was a social worker who already sat behind the HIPAA wall. For those of you that aren't familiar with what HIPAA stands for, it's the Health Insurance Portability and Accountability Act. It protects all of our personal medical information so that people can't get to it and it can't be shared. It is the exact barrier that kept us from having success in outcomes for mental health patients. So the idea was that the justice coordinator would start with the communication piece. When a new name came across her desk, she would start to reach out to our mental health providers in the area, to the hospital, and to other people who might be able to point us in the direction where this person was already plugged into services. Once we're able to determine that they were plugged into services, the justice coordinator follows up with the care. What are we doing? What's not working? What are the other things that we can try to put this patient back into a living situation that works for them, but keeps them out of crisis? Unfortunately, a lot of times, mental health patients don't have resources. And so at times, the justice coordinator becomes their only advocate. And we work to try to find good placements for them and to help them make good decisions about their care and what that looks like. We couldn't do this alone. We had to have our whole community behind us to make this work. I told you that conversation was already going in Mason City before I arrived. And we had good cooperation from our local community to do that. That included our hospital and the emergency room, which was our primary stop for psychiatric triage, and then placement after that. We had all of our mental health providers in the community come to the table and say, yeah, we're in. We want to help you do this, and we think we can do better than we're doing right now. And finally, we brought a federally qualified health center to Mason City. This is a facility that provides care to people who typically don't have it, those who can't afford it, or those that don't have access. Think of people maybe coming out of jail or incarceration, those other kinds of places where they don't have insurance and they don't have any way to get medical care, mental health care, or dental care. We brought that clinic to Mason City and it opened last October. They've since seen 2,400 new patients, which is filling a huge gap in our community. We also continually to meet regularly as a group. We talk about what works, we talk about what doesn't work, and we talk about staff changes, and we have to keep having the conversation to make sure that we're all on the same page. And finally, in 2017, we applied for and received a mental health planning grant. That was an opportunity for us to write a plan for a community mental health response that helps to improve outcomes for patients. One of the things we learned as we were completing our grant application was we had some communication issues. Sometimes these were as simple as an officer bringing a patient into the ER and not sharing all the information they needed to with the triage nurse to get this person appropriate help. Sometimes it was jail staff who would lose communication with the patient when they were discharged from jail, and we couldn't get them referred back into community services. Sometimes it was a complete breakdown between the hospital and a provider. So we worked really hard to look for solutions to that problem. And the biggest thing we were able to do was come up with a release of information with all of the parties in the discussion on it. That release can be started at any point in the process now by any group, any entity, or the patient, and can be shared so that we can share information across those lines. It has worked very well for us to start to share information. Before we talk about results, I want to point you back to the data set that I started with. I want you to pay particular attention to the difference between year 2017 and 2018. And I think I can point you in the direction of why those numbers are starting to go down. I'm going to talk about 3 cases tonight. The first one is Joe. Joe landed on our radar in Mason City in November of 2016. Joe was homeless and disabled, obviously disabled. And our department received 19 calls for service over 4 weeks related to Joe. At the time, we were just getting ready to start the mental health, or the Justice Coordinator program. And so I happened to be heavily involved with this one, with our Justice Coordinator at the time. We worked to offer Joe every program, every service, and every resource that we had in Mason City as an option. Trying to get him placed before it really got cold in the winter, trying to get into a place where he would have food. Joe was very, very proud. He was homeless, but you wouldn't know it. He was always clean. He always took care of himself, and he was never a danger to himself or to anybody else. Joe ended up rejecting all of our offers for help. We were able to finally get him a bus ticket back to a community where he'd lived before. He wanted to go back to the shelter there. We did that. He made the trip, and as far as we know, Joe is still there. You might look at me and say, Jeff, that's a bad example. You didn't help anybody in that case. And I would tell you that I disagree. I think that this is the first time that we had circumstances that we could really draw on, where we could lean into our community and say, we need a solution. And everybody stepped up. We gave Joe every option that we had. And even though he didn't choose one of those, it worked out okay for him in the end. The next patient I want to tell you about is Mary. Between 2015 and 2017, Mary had 260 calls for service with our department over a 3-year period. 120 of those calls were medical calls. Think 2 cops, an ambulance, and an ER visit. Remember that number from a little bit ago? $2,000 per occurrence. We spent over $240,000 in public safety resources trying to treat Mary in that 3-year period. We were able to get her in to see a local provider in late 2017 and early 2018. Because of the work that they were able to do, they were able to find a new way for her to take her medication, to make sure she got the right dosage, and help stabilize her situation. Today, she is functioning much better. We see her far less frequently, and in 2018, we only had 15 calls for service on her for the whole year. The third patient I want to tell you about is Erica. Erica is a fairly recent case. We had 49 calls to her residence over 4 months. Erica lived in her own house with a relative who also struggled with mental illness. We routinely went through our ambulance calls, but could never get a commitment from her on going to the hospital and trying to make a difference, trying to make an impact. The Justice Coordinator was finally able to reach her caseworker, and we're able to get her in to see her doctor for some psychological testing. The results of that testing opened up some new opportunities for her in regard to treatment and care. We're able to get her out of her home and into a facility where we could provide better health care for her, and in turn, better mental health care. We've had no calls on Erica since we put that into place. The Justice Coordinator part of this really works. Every day, we send yesterday's calls for service out in an email to all of our mental health providers in our community. So they can look at the names, they can look at the circumstances, and they can intervene ahead of crisis with their patients that they already know. The idea is that we're catching where somebody's not taking medication. We're getting them back in when they miss an appointment. And if they just need a checkup and something's not right in their world, we're getting them back into their environment where they're comfortable dealing with a provider before it goes to crisis. So we've been at this for about 2 years. We've learned a few things. I think the 100 call for service decline that you saw from 2017 to 2018 is a good start. I can't point to the exact reason that we've done it, but I'll tell you what we've learned. There are still complex mental health cases on both ends of the spectrum, those who need more intensive care, sometimes 24 hours a day, 7 days a week. Then we have people at the other end of the spectrum who live very independently, but due to their mental health, maybe don't live in the reality that you and I do. We have not been able to move the needle on either of those two groups, but we have been able to impact the middle, the big part of the bell curve, by reaching out and trying to plug people back into their safety net and their support system. This wasn't done overnight. It takes an everyday, every time you have a conversation with a provider about what's going on kind of conversation to keep the program going so that we have support and we make it work. We have improved communications. We've done that through survey and study in our grant between mental health providers and the police, mental health providers and jail staff, the hospital and mental health providers. We've done that. You can move the needle, you can improve the outcomes. We have reduced incarceration. We've reduced the criminalization of mental health because now we're able to offer patients in crisis options and resources instead of jail. And so that's been a very good deal. We've reduced the public safety demand, that $2,000 per trip. If you look at the 100 calls that we reduced that last year, that's $2 million. That's a good deal. I'm here to tell you that the solutions to mental health crisis in your community are a community issue, not a law enforcement issue. I want you to think back to that face, that person you were thinking of that you know that struggles with mental illness. And let's assume tonight that after this is over, they're in crisis. How do you want us to respond? Do you want a traditional mental health response? Or do you want the community mental health response? I want you to leave here and help us continue to break barriers in our communities. Go out and look for opportunities in your communities to work with the police and to work with mental health institutions to improve outcomes. That face in the back of your mind will thank you. Thank you.